I'm Dr. Vineeth Mohan. I'm a member of the Endocrine Society's Advocacy and Public Outreach Core Committee. I'm a practicing endocrinologist at Cleveland Clinic, Florida, located in South Florida. Like most general endocrinologists, I treat many patients with diabetes every day, but my areas of special interest include thyroid and parathyroid disorders. I hope that you're all enjoying your endo experience in San Francisco so far and taking advantage of the interesting sessions and insightful discussions that our annual meeting always has to offer. As you know, the topic of today's conference is diabetes. Diabetes is diagnosed by the finding of high blood sugar. Blood sugar rises if the pancreas is unable to produce an adequate supply of the hormone insulin. Blood sugar can also rise if the body doesn't respond to insulin appropriately or becomes less sensitive to the action of insulin, a condition called insulin resistance. Common causes of insulin resistance include weight gain and physical inactivity, which are felt to be contributing to the worldwide epidemic of diabetes that we're currently seeing. Other factors leading to insulin resistance are also being understood and will be explored by two of our presenters today. The ultimate impact of diabetes is to produce greater risk of various medical complications and premature death. This issue will also be tackled by one of our presenters today as well. Let me now introduce to you our presenters. We're very pleased to have with us today Dr. Peter Liu, who's visiting professor and senior investigator at the Los Angeles Biomedical Research Institute at Harbor UCLA Medical Center. Dr. Catherine Hackman is an endocrinologist at the Alfred Hospital in Melbourne, Australia. And finally, Dr. Paresh Dandona, Distinguished Professor of Medicine and Chief of the Division of Endocrinology, Diabetes and Metabolism, University at Buffalo, the State University of New York. Over the next 30 minutes, each speaker will present their findings. Following all the presentations, we'll open up the microphone for questions. Please note that this conference is also being broadcast live by webcast. So I wanted to welcome all of those joining us online today as well. Because we're broadcasting live, it is important to address all remarks into a microphone so that those joining us online can also hear the full discussion. Journalists who are joining us online will have the opportunity to submit questions at the end of our question and answer period. I'd like to now invite our first presenter to the podium, Dr. Liu.
So the problem with the modern 24/7 society is that we eat whenever we want, we work whenever we want, and we do whatever we want. The problem with this lifestyle is that it doesn't value sleep. We don't think sleep is important, we don't think it matters, we don't think it's harmful to our metabolic health. But in fact, what I'll show you is that sleep is important. Having enough sleep improves your insulin sensitivity, and that can reduce diabetes risk and the risk of obesity. So this slide just shows what I just told you, and this is a survey conducted by the National Sleep Foundation in America. And it shows that 40 to 50% of Americans report sleeping less on weekdays compared to weekends. There's been a lot of studies examining the effects of altered sleep on insulin sensitivity. This summarizes the better studies, better from the point of view that they used a gold standard method to assess insulin sensitivity, either the hyperinsulinic euglycemic clamp or minimal model of intravenous oral glucose tolerance test. Now what these studies all show is that sleep restriction reduced insulin sensitivity somewhere between 15 to 25%. And what's also relevant to this slide, not only these 5 studies, but all the studies, was that these studies were performed in normal individuals who self-reported normal sleeping patterns, and they were artificially brought into a lab and their sleep was manipulated. Other studies have also shown, some very elegant studies, that it's not just sleep, it's slow wave sleep, which is the deep sleep, it's the restorative sleep. And 2 elegant studies, one which used acoustic stimuli to specifically reduce slow wave sleep, and another which used acoustic stimuli throughout the sleep period, both showed a 25% reduction in insulin sensitivity with these interventions, these noise interventions. So as I mentioned before, previous work has found changes in insulin sensitivity with sleep loss or manipulation in normal sleepers. So what we wanted to do was we wanted to investigate the effects of catch-up sleep on insulin sensitivity in men with lifestyle-driven chronic intermittent life sleep restriction, a real-life population. So we recruited men between the age of 18 to 50. They gave a history of at least 6 months of sleeping at least 25% more on weekends compared to weekdays. They had restricted weekday sleep, and they were normal, and they were not. They didn't nap. They weren't shift workers. There was no other sleep disorders or any other significant medical condition. And actually, we verified this by ActiWatch. So this is an example of an ActiWatch. So basically, they wear this at night, and if they're moving, then they're awake. If they're not moving, then they're asleep. It's really as simple as that. It's a little bit more complicated than that, but it's kind of a simple principle. So we verified objectively that they were doing what they told us that they were doing. And we verified this at screening for the 2-week period before screening, as well as for the 2-week period before our intervention. And what our intervention consisted of was A, B, and C, and they received 2 of the 3 conditions because we thought it was too much to ask people to come in for 3 weekends. And they received these conditions in random order. And the 3 conditions were, Group A was 10 hours time in bed, so catch-up sleep. Group B was 6 hours time in bed, so sustained sleep restriction. And Group C was 10 hours time in bed with slow-wave sleep suppression using acoustic stimuli for the reasons I mentioned before. So to show you more elegantly what happened, they came into the lab on the Friday night. They left the lab midday on Monday, and on Monday morning they had an oral glucose tolerance test during which 18 blood samples were drawn, and by minimal model we assessed insulin sensitivity. And during this condition here, acoustic stimuli was administered to reduce specifically slow-wave sleep. And this is an example of what we did. So the sleep tech through the night would monitor the EEG. When she saw 2 consecutive slow waves, she administered noise, and then the person woke up sufficiently so they went into light sleep but didn't actually wake up. So that was the key of this intervention. You were able to take people out of deep sleep into light sleep, but we didn't wake them up. And this is what we did for that part of the intervention. 315 people replied to the advertisement, 49 were screened, 21 were randomised, 19 completed, 8 in the catch-up sleep versus the sustained sleep restriction, 6 in the long sleep versus the noise intervention, and 5 in the sustained sleep restriction and the noise intervention. They were young men between the ages of 19 to 49. They slept at home on average about 6 hours and 12 minutes on the weekdays. And really, if you think about it, that is not a lot of sleep restriction. That's one of the messages I want you to take, is that this was a population which didn't really have a lot of sleep restriction at home, but yet we showed that extending their sleep improved their insulin sensitivity. On the weekends, they slept on average 8.5 hours, and they extended their sleep on average by 37%. And even though they were required to self-report this for at least half a year, on average, they lived this lifestyle for 5 years, and in one individual, he had lived this lifestyle for 15 years. And this has summarised their sleeping patterns at home, and as you can see, on average, they slept 6 hours per night on the weekdays, and on average, they slept 8.5 hours per night on the weekends. And as you can see, our intervention of 10 hours per night was a saturating dose of sleep. The 2 weekend interventions were comparable. And the next couple of slides just verify that we did what we said we were going to do. So our sleep restriction protocol actually reduced sleep, verified by polysomnogram. There were differences in sleep efficiency, latency, and arousal index that were consistent with what we wanted to do. Our slow-wave sleep intervention also reduced slow-wave sleep, both in absolute minutes as well as a proportion of the total night. And this was also consistent with power spectral analysis, which is a mathematical way to actually quantify slow-wave sleep. So basically, these 2 slides show that we did what we said we were going to do. And this is what we found. We found that in those individuals who had the catch-up sleep versus those who had sustained sleep restriction, there was a 31% increase in insulin sensitivity as measured by a gold standard minimal modelling of an oral glucose tolerance test, a frequently sampled oral glucose tolerance test. Interestingly, despite the other data, we showed no effect of slow-wave sleep on insulin sensitivity. There were no changes in disposition index, glucose area under the curve, or insulin area under the curve. Markers that suggest that pancreatic insulin secretion was increased. The C-peptide insulin HOMA-B suggested that during catch-up sleep there was an increase in insulin secretion. And this data here verifies our oral glucose tolerance test data, showing that the catch-up sleep improved insulin sensitivity using other markers of insulin sensitivity, the HOMA-IR and the Quickie. So in conclusion, despite this lifestyle sleep pattern, insulin sensitivity showed an improvement following 3 nights of catch-up sleep compared to sustained sleep restriction. Acoustic stimuli interventions showed no changes in insulin sensitivity in this cohort, and larger studies are shown. So in summary, what we've shown is that despite the fact that we don't think sleep is important for our metabolic health, it is important for our metabolic health. Having enough sleep means that you will have improvements in sensitivity, which, as we heard from our moderator, is the predictor for diabetes. Thank you.
Thank you, Dr. Liu. I think I and most of my medical colleagues would probably qualify for being a part of your study. And I'm glad this type of information is going to get out there. Now I'd like to introduce Dr. Hackman to the podium as well.
Do I just escape this?
No, just hit space. Yep.
Okay. Hi, so I'm a doctor and I specialise in diabetes, and I work with the lung transplant unit at the Alfred Hospital in Melbourne. And the Alfred is one of the major trauma, teaching and research hospitals in Melbourne, but it's also the hospital that performs the most lung transplants in Australia, and it also performs a significant proportion of lung transplants worldwide each year. So clinically on the ward, we're involved quite often in the care of these patients because diabetes is common following lung transplantation, and we found that the patients with diabetes following their lung transplants have had some quite stormy courses. So we wanted to look into these patients and the effect of diabetes on lung transplant patients in a little bit more detail. And I can't help myself, I've got to cut to the chase and tell you what we found straight away. So we found that diabetes was by far the strongest risk factor for mortality following lung transplantation. And in addition, we found that survival in the patients with diabetes was half of the duration of survival in patients who didn't have diabetes. So a median survival of 5 years in patients who had diabetes, a median survival out to 10 years in patients who did not have diabetes. And the significance of this is that compared to the complexity of a lung transplant, diabetes is pretty simple. We've got all the tools to screen for it, to detect it, to manage it. And so it's possible that if we start actually managing these patients' diabetes, then we might be able to get dramatic improvement in patient outcomes following their transplants. So just to put this in a bit of context, although it sounds a bit rare, lung transplantation is actually a lot more common than you think, and it's occurring with increasing frequency worldwide every year. And it's a life-changing, life-saving procedure. Patients, when you meet them when they're waiting for their lung transplant, they're gasping for breath just to get through a sentence. And straight after their transplant, they can speak freely and they're going to the gym within a couple of weeks. The patients who are undergoing lung transplantation are young compared to other transplant recipients. So many patients have cystic fibrosis. A quarter of patients undergoing lung transplantation are aged only in their 20s. And yet these young patients are having relatively poor survivals. So compared to other solid organ transplants like heart, kidney, liver, lung transplant recipients have relatively poor outcomes. Only 30% of patients who undergo a lung transplant are still alive 10 years later. So 70% have died by 10 years. And it's well known that diabetes is a common complication following solid organ transplantation. And that's because patients who undergo transplantation require immune suppressing drugs so that they don't reject their transplanted organ. And lung transplant patients need particularly high doses of these immune suppressing drugs, and a combination of these drugs. Usually patients are on 3 agents, and all of these agents, but 2 in particular, really increase the risk of diabetes. So by 1 year after transplant, more than a quarter of patients have developed diabetes, and it's nearly double that by 5 years after transplantation. It's well known that diabetes is a risk factor for mortality and a risk factor for graft dysfunction in other organ transplants, such as kidney and liver, and it's been fairly well studied, particularly in the kidney transplant recipients. But the effect of diabetes in lung transplantation has not been studied in detail. So we wanted to ask a few questions. We wanted to know whether, firstly, did diabetes affect survival following lung transplantation? And we also wanted to know whether the timing of onset of diabetes was significant. So, for example, does a patient who has had diabetes for 10 years before their transplant have a different outcome to patients who are diagnosed a year or 5 years after their transplant? So we took 10 years' worth of patient data from our institution. We only looked at adult patients aged more than 16 years, and we looked at all of these patients and we classified them using the World Health Organization criteria, the current criteria, for whether they had diabetes or not. And in addition, we classified the timing of onset of diabetes by the date of diagnosis. And so we had 387 patients that we analysed, and of those 387, we could clearly classify diabetes status in 367. And as well as looking at diabetes, we also looked at all the other risk factors for mortality following lung transplantation. So, of course, age, patient weight, their underlying lung disease. So the commonest reasons for having a lung transplant would be end-stage obstructive airways disease, such as emphysema, cystic fibrosis, pulmonary fibrosis, and then there are some rarer conditions like hypertension within the pulmonary arteries. We also looked at their lab function, and we looked at their total cholesterol and triglycerides before transplant and their renal function. So coming to our results in a little bit more detail, first of all, we looked at mortality, and we looked at the rates of death in the patients who did and did not have diabetes. And 40% of the patients who didn't have diabetes died over this 10-year study. 63% though of patients with diabetes died. So 40% died without diabetes, 63% of patients with diabetes died. And then we wanted to look at duration of survival between these groups. So this is a survival curve, and is my mouse going to work? So time 0 is the time of a lung transplant when 100% of patients are alive. And over the next few years, patients will die, and this is out to 5 and 10 years. So I'm going to start with the survival curve of patients who did not have diabetes in green. And you can see that the patients who didn't have diabetes, if we look at the median survival, so the time at which 50% of patients have died, the median survival was 10 years. And remember that from the worldwide data, 30% of patients are normally alive 10 years after transplant. So here we've got patients without diabetes have a median survival of 10 years, which was better than we expected. And if we compare that now with the patients who did have diabetes, and I'm going to show 2 curves together because they're so similar. So the curve in blue is patients who had diabetes already known about before their transplant, and the curve in red is patients who were newly diagnosed with diabetes after their transplant. And I've lost my mouse again, but you can see that the median survival for these groups is 5 years or 4.3 years, but essentially the same. So survival of 5 years in patients who had diabetes, whether it was diagnosed pre or post-transplant, 10-year survival in patients who didn't have diabetes. So far we've just looked at diabetes as the only risk factor for death, but of course we've monitored all the known risk factors for mortality following transplantation, and when you put all those risk factors together, diabetes was still by far the most potent risk factor for mortality. So irrespective of the presence or absence of other risk factors, patients who had diabetes, whether it was diagnosed before their transplant or at day 100 or at day 1000, had 5 times the risk of dying as patients who did not have diabetes. And so we, of course, wanted to know, well, what's the cause of death in these patients? Why are they dying so much sooner? And surprisingly, there was absolutely no difference in cause of death between patients with and without diabetes. So the commonest cause of death in this entire population was chronic rejection of the transplanted organ. and chronic rejection of the transplanted lung is the commonest cause of death in worldwide data in patients who survive beyond the first 6 months. So specifically, patients who had diabetes weren't dying of the complications that we might have expected. So classically, diabetes complications, we'd think of heart attacks, strokes, vascular diseases, but these patients with diabetes had no higher risk of those classic diabetes complications than patients who did not have diabetes. So, in summary, lung transplantation is a complex, expensive procedure. Organs, of course, are very scarce, and the patients who undergo these procedures are young patients. And at the end of this pretty miraculous surgery, the main cause of mortality is diabetes. And this is the first study that's looked at diabetes, that's classified patients according to their diabetes status and assessed mortality by diabetes status, looking at it so specifically. And it's also the first study worldwide that's determined whether the timing of onset of diabetes has an effect on survival. And of course we've shown that patients with diabetes have an increased mortality rate and are surviving about half as long. But there is some good news here, because compared to the complexity of a lung transplant procedure, diabetes is pretty straightforward. We've got all the tools to screen for diabetes, to detect it early and to treat it. It is, of course, a team approach, but treatment of diabetes is inexpensive and it's safe. So it's quite possible that if we get on and start screening patients for diabetes early and managing the diabetes, we could potentially double patients' lifespans following their lung transplantations, or dramatically improve their outcomes. And of course that's what our further research is looking at now. Thanks.
Thank you, Dr. Hackman. Yes, those are very staggering differences in survival, and it will be interesting to see what type of interventions might modify those risks. Now I want to invite Dr. Dandona to the podium.
Right, I just proceed straight ahead. So what I'm going to be talking about this morning is the syndrome of hypogonadotropic hypogonadism, which we described for the first time in 2004, showing that 1/3 of type 2 diabetics have low testosterone levels, and that the origin of this low testosterone is in the hypothalamic, at the hypothalamic level, and therefore you have the hypogonadotropic hypogonadism. Now, at the stage that we described it, and this was essentially a gift of Viagra, I like to say, when Viagra got licensed by the FDA, the urologists began to prescribe it like there was no tomorrow. And then they found that there was a whole lot of patients who were not responding. And these patients, non-responders, got referred to endocrinologists like me. And of course, we like to systematically investigate patients, so we discovered a few cases of prolactinoma. That was fine. But of course, I had an epidemic of hypogonadism on my hand, something that had not been described before. So when I checked with the laboratory, they confirmed that the assay was okay, and therefore then we thought that we had discovered something new. Now this prevalence of 1/3 of type 2 diabetics having hypogonadism has now been globally confirmed in various studies from various parts of the world, including Australia. Matt Grossman was talking about this only the other day. And we've now extended it to obesity as well. So 1/4 of obese people will have low testosterone concentrations, and with it low LH and FSH concentrations, so that they too would be classified as hypogonadotropic hypogonadism. Finally, one other introductory comment, and that is that our most recent study, published about 3 or 4 months ago, shows that children between the ages of 14 to 20, if they're obese, have testosterone concentrations which are 50% lower than those of normal children, and these children will probably have problems getting to sexual maturity and adequate fertility. So it's a very important epidemiological message. Now, the study that we presented here sort of attempted to ask whether type 2 diabetics with hypogonadism had a greater level of insulin resistance than the rest, and then the next part of the study was that if they were given testosterone over a period of 6 months, to restore their testosterone concentrations to normal, whether the insulin resistance would be reversed and that they would come back to the baseline where they belonged with type 2 diabetes in the background, which, as you know, is a condition characterized by insulin resistance. So I think we'll cut all of this short and get on to the data. And here it is. Right now, on the basis of an NIH-supported study, we've looked at 81 patients comparing their insulin sensitivity status. And you can see that the age is comparable, BMI comparable in the two groups, so BMI is higher in the hypogonadal group. Total testosterone is about half, free testosterone is about half as well, or just more than half, and calculated free to those who don't have proper measurements of free testosterone. That's a shortcut using SHBG and total testosterone, and again, that is low. SHBG itself is known to be low in insulin-resistant states. LH and FSH were, well, LH was significantly lower, FSH was lower but not significantly so, and the testicular size was comparable in the two groups. PSA, prostatic specific antigen, identical, A1C reasonable in both the groups, 7.1, 7.2, and lipid levels were also sort of comparable and not significantly different, except that the HDL was low, consistent with lower, somewhat lower, consistent with the increased BMI. And of course, waist circumference and waist hip ratio was higher in the case of hypogonadal patients. Now, this is something worth sort of noting, that in these patients, the fat mass, whether you look at total fat mass or regionally in the arm, leg, or the trunk, it's significantly higher. And this is an important index because I'll be talking about the change following testosterone, and the total lean body mass is also higher because they are heavier. Okay, so now, as far as insulin resistance is concerned, using the euglycemic hyperinsulinemic clamp technique, you can see that there is a significantly lower insulin sensitivity level in the hypogonadal group, and even if you correct for the body weight and age, it's still significantly lower by about 30%. Now, the effect of testosterone. So once you give testosterone for 6 months, to restore the total concentrations of testosterone to mid-normal range, and we were carefully titrating this, and titrating the dose to make sure that it was in the mid-normal range, and you can see now that in this group, with a BMI of 37 to begin with, a total testosterone at the beginning was 256. After treatment for 6 months is about 562, having been maintained at that kind of level throughout the period. Free testosterone also goes up dramatically. Calculated free testosterone goes up. SHBG comes down somewhat, but not dramatically. PSA rises a little, but still very well within the normal range, and therefore, from the prostatic point of view, quite safe. And testicular size actually shrinks, and that's something you'd imagine because LH and FSH would be suppressed. Placebo side showed no significant change, and then lipids didn't change significantly. Sexual desire and satisfaction with erection improved significantly. And then, of course, the issue of insulin sensitivity. And you can see a rather dramatic 25% increase in insulin sensitivity or reversal of insulin resistance on the basis of glucose infusion rate after the administration of testosterone for 6 months. So in the hypogonadal state, you have resistance, and almost all of it, 30% versus 25%, is reversed following testosterone therapy. So now, let's look at some other interesting data. So over this period, the weight overall went up somewhat, but not significantly. Waist-hip ratio did not change significantly, but total lean body mass increased significantly. Arm lean mass also increased significantly, and leg lean mass had a trend towards increase, but did not increase significantly. And the same way, converse of that, all indices of fat mass diminished. And overall, the short part of this message is that 2 kilograms of fat were replaced by 2 kilograms of lean body mass. Then we went on to look at some of the biochemical indices, and as you'd imagine, insulin concentrations fell with the sensitization to insulin. Glucose concentration fell somewhat. HOMA-IR also fell, which is an index of insulin resistance, as has been mentioned earlier on. Free fatty acids fell dramatically. You can see a fall of 670, which is rather high, coming down to 410, which is somewhat near the normal range. Normals have it around 300. C-reactive protein fell. TNF-alpha trended downwards, but not significant. Leptin concentration fell significantly. And then some of the cellular parameters, and I need to explain somewhat here, because these are not commonly talked about things. SOX3 and IKK beta are two elements that interfere with insulin signaling at RS1 level. And that's well established. And both of those mediators fell. PPAR alpha, which is a mediator of increased glucose oxidation, increased. PPAR gamma and GNK1 did not change. So the conclusion from all of this is that hypogonadal patients with type 2 diabetes, and 1/3 of the population of type 2 diabetes has them, leads to an insulin-resistant state and a pro-inflammatory state. And the pro-inflammatory state may be contributing to the insulin resistance by interfering with insulin signaling. And 6 months of treatment with testosterone reverses almost altogether the insulin-resistant state, and with it exerts anti-inflammatory effects consistent with the reversal of the mechanisms that lead to insulin resistance. Now, this is an ongoing study, so you'll be hearing more about it as we go on, because we have fat biopsies and muscle biopsies from these patients, and you have a large body of data over the next couple of years emerging showing what testosterone does to the body in metabolic terms beyond what we have attributed to it till now, and that is in terms of sexual function. Thank you very much.
Thank you, Dr. Dandona. So to summarize our presenters, Dr. Dandona makes a connection between low testosterone and insulin resistance, and improvement in insulin resistance with testosterone therapy. Our second presenter, Dr. Hackman, showed a major impact of diabetes, even diabetes of short duration, on survival following lung transplant. And our initial presenter, Dr. Liu, looked at insulin resistance and its relationship to sleep, and how a fairly simple intervention can have a favorable impact on insulin action. I would like to open up the microphone for questions from the audience. Please do state your name and affiliation when asking questions, and do speak into the microphone for our online audience.
I'm Sarah Allen from the Lens of Diabetes Endocrinology. Dr. Hackman, I'm wondering if you can comment on whether there's any scope to alter the immunosuppression regimen that's used in patients so that it might prevent the diabetes.
Can you hear me? It's difficult in lung transplant recipients. There's always work and changes in the immune suppression regimen. In renal transplants, the glucocorticoid, the prednisolone doses, can be reduced quite dramatically, and the same in heart transplant. But lung transplant recipients in particular seem to need very high doses of glucocorticoid, which we give in the form of prednisolone. There's some work going on in Melbourne, again in the kidney transplant population, looking at split dosing of prednisolone, so giving half the dose in the morning and half in the evening, to perhaps cause less of a spike in blood sugar in the early afternoon, which is what occurs currently. At the moment, all lung transplant patients get all their immunosuppression from the glucocorticoid in the morning with split doses of their other immune suppression. The type of so there are a couple of classes. The key classes of immune suppression drugs that cause high blood sugars is the glucocorticoids, so prednisolone, and the calcineurin inhibitors. And there's two main types used there, cyclosporin and tacrolimus. And in recent years, there's been a switch to tacrolimus because it has a better immune suppression effect. Both of them cause diabetes or impaired glucose tolerance, but the tacro possibly a little more so. So there's that balance between high blood sugars versus not having organ rejection. And
Dr. Dandona, I'm wondering, I probably missed this in your presentation, but what was the type of testosterone replacement that you used?
We used injectable testosterone in this case, just that I'm still slightly old-fashioned, and I just wanted to make sure the drug got into the body and that we weren't sort of dependent upon, creams smeared over the body and not getting in.
We have a question from Mary Wallens from health.com. She said, this is for Dr. Hackman, were specific blood glucose readings a factor? Higher readings, higher threat?
That's a great question. This study was a retrospective study, so we looked at all the patients' data over 10 years and we diagnosed diabetes based on their blood sugar levels. And it was not possible. I think the question which is very relevant is, does the control of diabetes, does glycemic control affect outcomes? And that's our further research. We couldn't get that data from a retrospective study, and that's what we're working on now. It's a great question.
Sarah Allen, Lancet Diabetes Endocrinology. Similar question. Did this take into account all types of diabetes, type 1, type 2?
Yes.
Did you have the classification data?
Yes. So none of the patients in this study had type 1 diabetes. Many of the patients going into their transplant had cystic fibrosis, and one of the complications of cystic fibrosis is CF, cystic fibrosis-related diabetes. So the patients with pre-transplant diabetes, not all of them, but predominantly were the patients who had cystic fibrosis. And when we did the analysis looking at all the risk factors for mortality, patients with cystic fibrosis are younger and they tend to get, they always get a double lung transplant, whereas patients with other types of underlying lung disease, such as emphysema, might get a single lung transplant. So in the mix of, when you look at all the risk factors together, overall patients with cystic fibrosis do a little bit better than patients who have different underlying lung disease. But irrespective of whether they had cystic fibrosis or not, patients with CF who had diabetes compared to patients with cystic fibrosis who did not have diabetes still had 5 times the risk of mortality. Yeah.
Okay. I want to thank all the presenters for being here today and everyone here in the audience and online. Enjoy the rest of the meeting.